Good evening, everyone. We're just going to give it about 1 or 2 more minutes before we start our webinar. Really appreciate everyone joining us for Focus Power Hour with the Kidney Month Renal Special being for March 2024. All right, let's jump into it. Looks like we're getting some more folks coming in. Really appreciate everyone's time today. My name is Dr. Davinder Ramsingh. I'm VP for Clinical Research and Development. I'm joined here with my partner in crime here, Dr. Peter Weimersheimer, who is VP for Clinical Implementation. We're really honored to have an expert list of panelists today to talk about, as we all know, March is Kidney Month, and we're really going to focus on the value of POCUS in the kidney disease patient, as well as for renal assessment. And with that, dive into welcoming our panelists, Dr. Abhilash Koratala, Dr. Ramesh Soundarajan, and Dr. Megan Leo. Would appreciate you guys very much for introducing yourselves, talk about the care settings that you guys work in, and how you started in the area of POCUS, and what areas of interest you have. Really, again, appreciate for your time. Abhilash, when you want to go first?
Yeah, hi. I'm Abhilash Koratala, one of the nephrologists from Medical College of Wisconsin, Milwaukee. I'm a nephrologist with interest in multi-organ point-of-care ultrasound, specifically bedside hemodynamic assessment. Thank you.
Hi, I'm Ramesh Soundarajan, a nephrologist practicing in the Chicago area. Been a nephrologist for 30 plus years. I've been an interventional nephrologist using ultrasound back from the early 90s for access and procedures, etc. But then got into the realm of point-of-care ultrasound for cardiovascular and volume assessment about 10 years ago. Basically went to a cardiorenal society and found that, hey, B lines can tell you about pulmonary edema. That got me piqued the interest on that side, and then subsequently learned about the cardiac evaluation, IVC, and then VEXUS, which is a huge part of how you assess volume status, which we'll be talking about a little bit, in which actually Abhilash has been my teacher for that a lot. So there's a lot of information you can get at the bedside.
Dr. Leo?
Yes, I'm Megan Leo. I'm an emergency medicine physician at Boston Medical Center, and currently the emergency department's medical director of quality patient safety, but the former director of emergency ultrasound for the emergency department. I'm also the current president-elect for Society of Clinical Ultrasound Fellowships, which is SCUF, which is a multidisciplinary organization that champions POCUS for all specialties.
Awesome. All right, let's go into let's start into the topic. I'd love to get the panelists to first weigh in on the evolution of point of care ultrasound, right? In terms of both for in the nephrology space, over the last decade, we've seen a lot of change going from just the evaluation of the use of ultrasound for procedural assistance or evaluating renal, ultrasound, but actually embracing the topic of whole body POCUS. Could you guys weigh in on what you've seen in the landscape across the specialty of nephrology?
Okay, I can go first. Sure. And like I said, using it as a procedural reason was the only thing we used back in the early 90s. But I remember attending a course on renal ultrasound by Charlie O'Neill from Emory University back in the mid-90s when he was teaching kidney ultrasound and said, hey, cardiologists are doing echo, nephrology should be doing renal ultrasounds. So that is when we got into that, and then we were using it again mainly for biopsies, but of course for imaging the kidney and etc. Then later on, like I said, we started using it for other things, volume assessments, and it has become a very, very important part of bedside diagnostic tool. I consider it an extension of the stethoscope at this point, and there is so much information you can get at the bedside with just a few minutes doing this. I also find it is a good reason to bring the medical students back to the bedside, because nowadays 80% of the time they're sitting in front of a computer. So this is a good reason to bring them back to the bedside and teach them how to examine patients and correlate clinical and ultrasound features.
Ramesh, that's an interesting concept that you just brought up about how the idea of POCUS is bringing back the physical exam, and you're saying patients are now finding students are finding value in going back and doing their assessments because now they have the assistance of ultrasound, where traditionally the standard physical exam is going a little bit more and more to the wayside as everyone just goes to the computer screen. Abhilash, any other insights? And again, and especially in nephrology, we've definitely seen a lot, and I know you've been a pioneer in the space for quite some time.
No, I definitely agree with Dr. Soundarajan that initially confined to kidney ultrasound or procedural guidance, we have expanded into multi-organ point of care ultrasound. And we just have to figure out how to best incorporate it into day-to-day practice, because we can't rely on single organ ultrasound, for example, lung ultrasound or isolated IVC ultrasound. Every sonographic application has its limitations. So yeah, going forward, that would be a major work for us to discourage isolated organ ultrasound and emphasize on incorporating multiple data points.
And I have a question for you and for the panelists. How did you get first involved in ultrasound? Like, did you see the value is in training, or was there a particular patient case, or you heard about another specialty embracing the idea of point-of-care ultrasound? And then, like, how did you first incorporate this into something that you wanted to learn about and teach?
For me, I would say I have seen emergency physicians utilizing ultrasound. That was my first understanding of ultrasound. Then I thought like kidney ultrasound is the most relevant to nephrology practice. So I learned kidney ultrasound, but very soon I realized that's not so helpful in day-to-day practice, because by the time nephrology is consulted, the kidney ultrasound is already there. It's done by radiology. If at all something is more helpful, I would say bladder ultrasound is more helpful to rule out Foley obstruction or differentiating ascites from bladder, like Dr. Soundarajan said before. Yeah, and then I graduated to easier applications such as lung ultrasound, because it's about interpreting the artifacts. So I thought it's easy to learn. But then again, soon I realized that's not enough. And then started doing focused cardiac ultrasound, then Doppler echocardiography, then VEXUS and everything. Yeah. So it's a gradual evolution. That's what I would say. It's a need-based evolution.
And that need was driven by the patients and you finding value
Exactly.
as you learned every component.
Absolutely, yes.
That's right. I mean, I share a similar story for the specialty of anesthesiology that very similar to the specialty of nephrology, that we looked to our emergency medicine colleagues, Megan, and seeing what they were doing and evaluating patients in the acute care setting. And many of us dawned on the fact that, hey, we have the same critical issues facing us in the operating room. You know, patients become suddenly hypotensive, hypoxic, unstable. Why don't we apply the similar concepts of point-of-care ultrasound that had initiated in the emergency medicine department to the OR? And it's great to see now that that's expanding. Peter, you have a great insight onto kind of the origins of ultrasound emergency medicine, and then Megan, love to get your insights as to kind of how it continues to expand. Oh, Peter,
Yes, I am. The discussion that's been happening about how ultrasound initially was actually looking at organ and structures, and one thing in emergency medicine early on was what to do with just the structure itself as the initial diagnostic decision node, and then going forward into functions and other more involved ultrasound. And Meg, I know you did your fellowship in renal ultrasound, so I want to talk about your interests or how you got involved in doing your point of care world.
Yeah, well, yeah, my fellowship project was on renal colic, which it was a challenging thing to study because it's such a a variable disease entity, and there's a lot of inexacts, I guess, with assessing it. But Yeah, I would say, point of care ultrasound in general in the acute care setting, it's a specialty skill to assess an acute complaint or an acute management of patients. So in regards to renal ultrasound in the emergency department anyway, we're mostly using POCUS to assess patients who come in with flank pain, patients who come in with new renal failure, in regards to assessing for obstruction situations, but also there's been quite a few cases where I've picked up just an undiagnosed polycystic kidney disease patient, that was their first touch to the healthcare system, and that's very easily picked up on bedside ultrasound, as well as I've had several just septic patients that were undefined sepsis, unknown source, and in a patient that's not able to verbalize anything, and you do a full assessment of the patient and find unilateral hydro, and you've just diagnosed a obstructing infected kidney stone that needs emergent percutaneous drainage. So those are all things that are really useful both in the emergency department or in the ICU. I also teach my residents that if they've got a patient with a fever up in the ICU, it's really difficult to transport them down to radiology to get a diagnostic study. So just doing a bedside ultrasound and looking at some of those key factors, including lung ultrasound, but also doing a renal ultrasound, looking at the gallbladder. Those are all kind of nondescript areas that can be a source of infection that can be picked up on bedside ultrasound. So yeah, I think around the time of my fellowship, like 12 years ago or so, there's a lot of energy around like how can we use point of care ultrasound to better take care of renal colic patients in general, because CT had been clearly defined as the gold standard for diagnosis, and also prognostics and guiding whether there would be a urologic intervention. But we were CAT scanning people a lot. 1 in 10 people in this country have been, epidemiology of it is that 1 in 10 people could have a kidney stone in their lifetime. And then many of those people get repeat stones. So as you can imagine, the people come in with flank pain, they're getting a CAT scan every time. That can lead to cost and also radiation. And each CAT scan is not benign. There is some degree of risk to cancer. So yeah, that was sort of like the focus in regards to how well does point of care ultrasound stand up to CT in regards to diagnosis, in regards to identifying hydronephrosis. Can we use that to help us prognosticate whether this patient's going to pass the stone on their own? Are they going to need a urologic intervention? Like those are all the questions that we're trying to be defined then. And then this particular study you have up here was, I think, the largest and multidisciplinary study looking at nephrolithiasis and comparing ultrasound first versus CT first. And it was a randomized control trial, which none of the other studies were randomized control trials, and essentially helped at least define what we already knew, that patients that got ultrasound first did just as well as patients that did they got CT scans first, and they had less radiation. So there's an argument there that it's certainly safe to do ultrasound first, and the patients are going to most likely do just as well. That's in a broad sense. I mean, of course, if you have patients who have fevers or have other risk factors, you probably want to get the more definitive study. But that's sort of my overview of using point of care ultrasound, at least for like the acute, presentation to the emergency department. Probably the most important thing to consider when deciding whether you solely do a point of care ultrasound for a complaint versus a CAT scan is how concerned you are for an alternate diagnosis, because ultrasound's not going to be adequate for identifying an alternate diagnosis such as diverticulitis or ischemic bowel or malignancy, those kind of things.
Yeah, great overview, guys, and look forward to diving in. Peter, before we go to the next slide, I look at this graphic, that Abhilash, that you had on one of your editorials of this whole body and looking at the heart, lung, kidney, and things like that. And while it says nephrology at the top, right, it's amazing how many specialties now you can replace that. I already mentioned about the specialty of anesthesiology, obviously emergency medicine originated, but internal medicine, looking at, so many different specialties, primary care, so many different specialties, right? Family medicine, obstetrical care. You could almost replace that title and have the exact same graphic below. So it's just interesting how the world has evolved in embracing POCUS, and trying to make it ubiquitous across a variety of specialties. And yeah, so look forward to let's dive in a little bit more into the topic of whole body POCUS, with the idea of looking at the patient who has kidney disease, and seeing how where are the key areas. This is just a zoom in on more detail on all the different areas that you can really be useful for evaluation and assessment, and as well as procedural support for that patient. We'll get to the procedural components in a bit, but first talking about volume assessment, right? I think one of the most common things we all are faced with is the idea of assessing where the volume status is of a patient who has kidney disease, right? Obviously something that's very challenging. And the topic of VEXUS, right, venous excess, is something that is closely tied to this concept, especially in the evaluation of kidney disease. Lots of different research in its evaluation, potentially some research showing its ability to evaluate and risk stratify patients who have worsening kidney function after, and being able to use that as a screening criteria. So let's go into VEXUS a little bit and talk about that. And like to go into just getting an overview of what is VEXUS, how it's used, and then talk about the different grades and how the panelists use it in their clinical practice. And Ramesh, do you want to weigh in first on what your thoughts are on VEXUS as you learned it, and how do you apply it on your patients?
Oh, sure. Like I said, I find it very useful in a lot of my patients in the ICU, and I see a lot of patients with cardiorenal syndrome. So my go-to, I start off first quickly. I mean, after your history and your physical examination, I do a quick cardiac ultrasound to see how the LV is functioning, how the RV is functioning, whether the LV is bigger than the RV, etc. And then I sweep down to the IVC and look and see what the IVC looks like. Now, if the IVC is large, it doesn't automatically believe that the patient is volume overloaded. And that's the thing. We used to believe a lot in the IVC, and we were making some erroneous conclusions. So that's when the VEXUS came in. Actually, the cardiac anesthesiologists from Canada, I think, were the ones, the Rolos group, were the ones who got this many, many years ago, and they brought it up and they described it. So I attended one of their conferences too, very, very illuminating. But then you go to, once you see the IVC is enlarged, then we say, okay, what is the next? Is this person truly volume overloaded, or it could be pulmonary hypertension? It could be other reasons for an enlarged IVC. If they're on a ventilator, it's also going to be confusing. So I go to you can see the hepatic vein from the midline in the anteriorly, but it's a way better picture you can get from the right upper quadrant. So I sweep down to the right upper quadrant with the probe indicator marked towards the head. And then I'm looking for the hepatic vein and the portal vein at that point. Now, sometimes, and interestingly, with more and more people getting fatty liver, sometimes you can't see the thick outer lining of the portal vein to say this is a portal vein. So that's when you need to put a color Doppler on and to identify the hepatic vein and the portal vein. And then once you identify which is the hepatic vein and the portal vein, you can use a color Doppler as a poor man's pulse wave to find out what the waveforms look like. If it's a very red and blue hepatic vein, then you know that there's both to and fro motion there. Then there is no some reflex going into the hepatic vein, but that can happen with tricuspid regurg and other reasons too. Then you look at the portal vein, which could be very nice and uniform flow. So if you look at the graphs here, you see that in the normal hepatic vein, the systolic is deeper, and there's a less intense diastolic, and both of them are negative wave, which means the blood is going away from the probe towards the IVC. But as the volume gets excess, you will see the systolic getting smaller and the diastolic getting bigger, and then you can get a single diastolic vein. We won't have time to go into all the details at this point, but that's a simple hepatic vein. The difficulty with the hepatic vein is the fact that you need an ECG to know which is a systolic and diastolic sometimes. And Abhilash has mentioned that many times. So you need a ECG monitor, which is not sometimes easily available to us in our ICU portalway or the ER machines or in your handheld machines. So I use the portal vein a lot, and the portal vein is normally a very nice and smooth flowing vein, and the flow is towards the probe, so it will be red in color. And then once you put the pulse wave Doppler, you can see that it is more soft and undulating, whereas when you start getting more volume excess, it starts getting more pulsatile. And if it's between 30 and 50%, it is somewhat pulsatile. And then if it gets more than 50%, or if it starts getting into the negative territory, like you see in that third picture, then it's more significant. Now, the third thing is a renal vein. And as a nephrologist, because most of our patients have CKD or dialysis patients, renal vein may not be as useful, but sometimes when it is useful, it is very useful because the renal artery and the vein are right next to each other. So you will get the artery, as you can see in the picture, the artery goes a positive wave, and you can see the renal vein will be a nice and smooth like the portal vein. Whereas if you start getting more congestion, it's going to become, you can see the waves here. You have a systolic and a diastolic, or it'll be all diastolic. Now, we are getting more and more, we understand that renal congestion or anasarca, or rather it's called nephrosarca, is a cause of AKI. And just decompressing the vein in those situations will make a huge difference. So sometimes we have dialysis patients who are having a pulsatile portal vein, even in the presence of hypotension. We then have to go ahead and tell them, put them on pressors, we need to pull fluid off. Or it could be patients who are in cardiorenal syndrome. We actually, the cardiologists nowadays listen to me a lot more than they used to in the past, or intensivists listen to me a lot more when I tell them, hey, this person needs diuresis or this person needs stops. So that is in short, VEXUS, which is a complicated story, but I wanted to try to at least tell you the scope where we need to be using that.
Yeah, Ramesh, thank you so much for, absolutely. VEXUS, complicated area, evaluating a staged approach of looking at IVC, then hepatic vein, portal vein, and then even to the renals, and taking that aggregation of all the waveform data to determine what the patient's potential congestion or right atrial pressure status is. Abhilash, could you, we have a grade system here that I think is fairly well, strongly evidence-based. Could you weigh in on how you apply that grading system? And also, in just clinical practice, all of those waveform data, are there some key takeaways that you look at to help you quickly risk stratify your patients when you're applying a VEXUS protocol?
Yeah, in general, when we think about VEXUS, we are talking about the effect of elevated right atrial pressure on venous flow and consequently on organ function. We are talking about congestive organ injury, right? So we generally know that elevated right atrial pressure is bad for the organs, even if your mean arterial pressure is well preserved, because it compromises the organ perfusion pressure. So why can't we just rely on right atrial pressure, maybe a transduced right atrial pressure? It's because if you demonstrate the venous flow is altered using Doppler ultrasound, that has more predictive value for congestive nephropathy than using right atrial pressure alone. That's one important thing. That's why we take the stress of spending additional time and getting all these waveforms. And the other reason why you do it in clinical practice is to assess response to your decongestive therapy. If somebody's right atrial pressure is very high, I mean, it's no-brainer that you give them diuretics or perform ultrafiltration depending on the need. But how do you know if that right atrial pressure is improving? In some patients, the IVC diameter might improve, and in some patients, it might not. So VEXUS will allow you to see how these waveforms are transforming in response to your treatment. When it comes to grading scale, IVC is your first point, because if the IVC is small and collapsible, your right atrial pressure is not elevated. If your right atrial pressure is not elevated, probably there is no point in assessing these waveforms further. So you call that grade 0. Well, this IVC less than 2 centimeters or more than 2 centimeters is a little bit of gray zone. You have to use your clinical judgment. You might have a small Asian patient whose baseline IVC diameter is 1.2 centimeters. And for that person, 1.8 centimeter IVC might be enlarged and plethoric. So you might want to just look at the IVC in two axes. In the short axis view, if the IVC is more circular instead of being elliptical, that's probably time to do VEXAS, even if it's technically not 2 centimeters. And like here you are seeing like mild and moderate alterations in the right half of these venous panels. And if the IVC is plethoric and you don't have any like severely abnormal pattern, but you have any combination of mild variation or normal waveforms, which means in these three waveforms in this diagram, if you don't have any of these right panels, that means you don't have severely abnormal pattern. So you can have a combination of any of those on the left side, like the first 6 of these figures. And if you have the right three figures there, you probably have severe abnormal pattern. So that's grade 1 or mild congestion. And if you have at least one severely abnormal pattern, it's grade 2. And if you have 2 or more severely abnormal patterns, that's grade 3 congestion. So you have a patient who has hepatic systolic waveform reversal and a 100% pulsatile portal vein. You don't even need to obtain a renal venous waveform, because in real life, getting intrarenal Doppler flow is difficult in most patients. So that way you can save time. In point of care setting, it's all about saving time and getting your data in an effective manner and utilizing it. Yeah.
Well, Peter, I was just going to say, like, excellent summary on VEXAS and how you apply it. And I think one of the key takeaways about what you mentioned about so many patients, right, with kidney disease have severely elevated right atrial pressures, and you have to adjust their congestion status through maybe diuretic therapy, as Ramesh, you brought up. But where do you stop, right? How do you know? And the idea, and if I gleaned anything from the panelists, that you were saying that perhaps VEXAS can provide another adjunct to be able to help titrate that therapy, to be able to get that person sort of in their sweet spot, because we all know that they're on such a tight rope of balance, right? Peter, any thoughts there?
No, I really like the point, Abhilash, you're making just about point of care, about, right, you're looking once and asking whether the information you have is enough, and if it's not enough, you get more information. But that concept of saving time, the whole goal is to get some more clinical information to change how you manage a patient. And an initial look may be enough, but if not, you expand your horizons and do more scanning to make that adjustment. So a really nice point.
Yeah, and not only sonographic parameters, but you take the whole clinical context into consideration. Because one caution I want to tell the audience is that VEXAS or IVC, none of these can differentiate pressure versus volume. Like, you cannot differentiate whether it's altered venous flows because of pulmonary hypertension or whether it's altered flow because of excess fluid, right? So that has clinical implications, because a patient with VEXAS grade 3 or severe congestion might benefit from pulmonary vasodilators if they have group 1 pulmonary hypertension, as opposed to a person with a heart failure might just benefit from ultrafiltration, and their IVC will become completely normal. And the previous patient with group 1 pulmonary hypertension may never get to normal VEXAS or grade 0, and they might still have like hepatic vein and intrarenal venous abnormalities. Usually portal vein improves a little better compared to this. So even when you're saying like VEXAS is greatly helpful in defining the endpoint of decongestion, we again have to apply clinical judgment and not like one endpoint fits every patient.
Also, one of the fantastic things about point of care is that you don't have to do a single point in time. So
exactly,
to your point,
yes,
right, you have an idea of what the cause is, you do an intervention, and then you have the probe in the pocket or the capacity to go ahead and look again and say, was my decision correct or not? And clearly, I think that, clinical medicine is challenging. And even though if you think you have the right idea, even from ultrasound imaging, potentially it's not quite right, but you have the capacity to look again and say, oh, what decision I made, what intervention I made is either not helpful, so I need to do more of that, or I need to change my decision to do it and think about pulmonary hypertension or a different cause of what I'm seeing. So it's a great point.
One interesting point I wanted to bring up was on the dialysis patients who have an AV axis, which can cause, if they have a high flow AV axis, that also can cause increased venous return, and they can cause pulmonary hypertension. And to differentiate that between somebody with volume overload pulmonary hypertension can be difficult, short of a right heart catheterization sometimes. But I was at a meeting a couple of weeks ago, and somebody from South America brought up a very interesting point, trying to do the same portal vein pulsation after occluding the fistula for 2 minutes and see if the portal vein reversal happens. I mean, if it stops being so pulsatile, then you know that the fistula is probably contributing to some amount of this volume. That was a brilliant idea. I just heard about this a couple of weeks ago, and I'm going to try to incorporate that into my practice.
Huh.
Yeah, one caution is though, like, so basically the principle behind that is, you're occluding the fistula, you're reducing the venous return. So if you reduce the venous return, your tricuspid regurgitation will get better, right? So your functional tricuspid regurgitation. But not every patient with right heart failure has that much of tricuspid regurgitation. So your portal vein waveform might not be really like altered. I know the case that you're exactly talking about. So in that particular case, the patient had torrential tricuspid regurgitation. And the portal vein was having like 100% pulsatility, so that improves. But if the patient's portal vein is like only 30% pulsatile, that might not be really you cannot use that as a test of exclusion. I'm very cautious person, so for every point I try to put out some caution. And probably like easier one is like you have suspicion for right heart failure from fistula, you use your linear transducer, and hopefully that has pulse Doppler now, and you just assess the flow right there at the bedside. And if your flow is elevated, then you can probably suspect and take it from there. Like you don't need to diagnose it, but you can at least guide further interventions.
Sure, absolutely. Access flows you can pick up with the AV. Nowadays, with all the ultrasounds, you can actually pick up an access flow, the velocity, and the flow, and that definitely is the first system. And absolutely, I mean that's available as a part of our POCUS too.
Yeah,
absolutely. Good
I mean,
point.
as an interventional nephrologist, you probably do it more. But even for general nephrologists, like we tend to neglect it. But I think it's in certain scenarios, especially in this kind of complex hemodynamic assessment, assessing access flows is definitely important.
You know, this is actually an excellent segue to your point about, for our panelists and audience, I have so great insights on the VEXUS. VEXUS, again, I would just, I'll go out and say it, complicated topic. You guys everyone really summarized it very well and really took it to how we could apply it clinically. But you also, I think the segue of, yes, there's other components of POCUS that you can use to help facilitate that assessment into your Abhilash. You mentioned, Ramesh, you mentioned, and Megan, look forward to getting your insights on this about the idea of like, well, there's many things that could still cause those VEXUS findings, right? It's not just always left-sided failure causing congestion. And how do you potentially evaluate that? Well, that lends itself to potentially going into cardiac and pulmonary ultrasound. How about, I'd love to ask the panelists a little bit about kind of just how you put that together, right? You have somebody who now, say a patient with known kidney disease or is on dialysis, comes in hypertensive, you're trying to, you may do the VEXUS protocol that we spend a lot of time talking on, but what other components of cardiopulmonary assessment via POCUS do you look at to try to get more insights to help you identify what the right clinical management decision is?
Yeah, so I think a lot of these patients are going to be coming in, short of breath or, with, visible peripheral edema, things like that. And it can get tricky, especially when you have a patient who has kidney disease, either on dialysis or even not quite on dialysis. There's still the fluid balance is a little bit trickier than just, should I give, diuretics or do I need to address the blood pressure, or what do I do first? So I think in general, doing sort of a full cardiopulmonary assessment is really helpful in those kind of undifferentiated shortness of breath cases, or a patient who clearly has some level of fluid overload, but may also have some other issue going on, such as COPD or asthma or some infectious thing going on. So our first approach in the emergency department is to assess the global ejection fraction of the heart. Also look for other signs that there might be another etiology, like, you may see some RV strain that's, chronic. You can assess that by identifying that there's some RV hypertrophy as opposed to like an acute RV strain that you'd see in a PE. And once you get the kind of the sense of what the global ejection fraction is, you move to look at the lungs, assess for B lines, and then also can look at the IVC. And just putting those three components together kind of gives you the overall cardiopulmonary picture. And then I could see, in the emergency department, the use of VEXUS is still, it's a little unclear how we can apply it in the acute care setting, just because, but I can see how in these more complicated renal patients, VEXUS could be a nice adjunct when you kind of incorporate it into, your full cardiopulmonary assessment. And the other really neat thing about especially lung ultrasound is that this is a dynamic process. So as you provide diuresis, was a study looking at providing positive pressure, with BiPAP, there was chronologically an improvement over time as the patient received therapy. Another study was done looking at patients undergoing hemodialysis kind of before, mid, and after, and that also was a dynamic process. So really, you can use this as real-time assessment of how you're doing with your, at least from a lung perspective, how your therapy is treating the patient. And it's subjectively the patient's report symptom improvement with those B-line changes as well. So that's just really another powerful thing about point-of-care ultrasound, as you're actively caring for patients and making medical decisions for them on how to best treat them.
I can come up with an experience this morning in the dialysis unit. I had two patients whose blood pressure was in the mid-90s, and the nurse was saying, should we put them on midodrine? And so immediately I pulled out my pocket ultrasound, and then quickly looked at the heart to make sure she didn't have a pericardial effusion. Looked at the IVC and it was small. And I said, no, I don't think we should give midodrine for right now. Let's just change the dry weight and bring it up a little bit. And that's something we do quite often. Of course, looked at the lungs to make sure there were no B lines.
Yeah, there's actually a question from one of our listeners about asking about effective ventilation or abdominal pressure or leg raising on IVC. I think the point that all patients who present, even if they're renal patients, aren't necessarily volume overloaded versus volume depleted, or in a dynamic fashion, you start giving someone who has a history of some significant heart disease and start resuscitating them, then all of a sudden that fluid has changed their hemodynamics for the negative. So I don't know if you want to comment about the concept of longitudinal assessment of volume. When you have a patient who comes in, are you doing leg raises or changing ventilatory settings for that assessment?
I think basically you're asking about the
leg raising
limitations,
is, right? Abhilash, go ahead.
No, sorry, go ahead. It's like nobody was talking, so I just chimed in.
No, go for it. Yeah.
No, that's okay. No, that's why I said.
This
Abhilash,
question is about knowing the limitations, right?
Right.
Yeah.
Like you're talking about a lot of things happen to the patient, like as they're admitted. And generally, like when you think about IVC ultrasound, you're talking about estimating right atrial pressure by looking at its diameter and collapsibility. And that collapsibility in the outpatient echocardiography laboratory, we are using SNF. SNF is a way of standardizing somebody's breath. But in the inpatient setting, everybody's strength of breath is different. A 80-year-old woman's strength of breath is quite different from 30-year-old muscular man's strength of breath, even if both these people are sick and in the hospital. And during the hospital stay, depending on whether the patient's condition is getting better or worse, that changes a lot. So you cannot really depend so much on these cutoff values, and you have to use clinical judgment. And about mechanical ventilation, yes, if the patient is intubated during the course of hospitalization, it's very difficult to compare the prior IVC diameter or collapsibility with the current IVC diameter and collapsibility. That's when you use VEXUS and see if that dilated IVC is just because of positive pressure ventilation, or Or is it because of positive pressure ventilation as well as other causes of elevated right atrial pressure that's being transmitted to the veins? And intra-abdominal hypertension, yeah, that's quite a problem in hepatorenal scenario where you have a tense ascites and that could be compressing the IVC. In such cases, you would use internal jugular vein to estimate the right atrial pressure instead of IVC. And the other problem with IVC is that people tend to confuse IVC ultrasound as a method to estimate right atrial pressure versus as a method to gauge fluid responsiveness. To estimate right atrial pressure, that's great. But to gauge fluid responsiveness, you probably shouldn't use IVC or central venous pressure for that matter, because that's essentially a static parameter. And by using this right-sided parameter, you cannot really predict at what point on the Frank-Starling curve a given patient is. In extremes, it's helpful. If the IVC is like 3 centimeters, not collapsing at all, yeah, probably the patient is not fluid responsive. The IVC is so small and collapsible, probably the patient is volume responsive, but in the middle ranges, you cannot predict. And also, we should think about why we are performing POCUS and why we are asking a focused clinical question. Is this really helpful? You do IVC ultrasound or you do left ventricular outflow tract velocity time integral with passive leg raise and determine the patient is fluid responsive, right? So, but what's the point of that focused clinical question? Just because somebody is fluid responsive, would you give fluids to this patient? It's not an indication for giving fluids, because fluid responsiveness is a physiologic state. You don't want to exhaust fluid responsiveness and push the patient to a pathologic spectrum. I guess, yeah, that's my caution about IVC in a few sentences.
Right.
Yeah, I would say
great.
like like at this point, I would say, at least in the critical care setting, really the measurements have really been shown to not be very helpful. It's sort of more this gradient of IVC, and as far as like normal being 1 to 2 centimeters with 50% distensibility, plethoric being above 2 centimeters with no distensibility, and then less than 1 centimeter with more than 50% is low, low right atrial pressures. And completely agree that you kind of have to fit it into the whole, cardiopulmonary assessment. And then, as far as fluid responsiveness, I would say at least in the emergency department, very rarely are we integrating VTI and all of those things. Not only is it, VTI measurement is really, even intra-rater reliability of VTI is very problematic. I mean, maybe with some AI applications that'll improve, but really the question is like, can this patient tolerate fluid? So, looking at that, global ejection fraction, looking at whether B lines are already present or not, and then seeing if the IVC, has some respiratory variation in it, maybe you feel comfortable to, okay, let's go ahead and give, a small bolus or reassess, sort of similar to how, you'd listen to lung sounds in between your fluid boluses back in the day, and kind of do similar with your ultrasound to sort of guide whether you feel like the patient can tolerate fluids if you're questioning that. So totally agree that the sort of isolated IVC assessment really is not helpful.
Exactly. So
And
fluid tolerance is probably more important than responsiveness.
Right. And I think also there's a bit of a common theme that this is a tool that helps out with clinical assessment, but ultimately it's a patient in front of us. So even the fact that a patient is fluid tolerant clinically doesn't mean that that patient really needs fluid at all. And so it's using judgment with the tool in front of us to manage the patient. So great points.
Yeah, Peter, I know, I mean, and to the panelists, we could talk about, volume assessment and volume responsiveness for the entire hour, right? Because it's such a, but I appreciate the, the identification of the value for congestion status, looking at the modalities we've discussed to be able to assess that. And then the insights about, fluid responsiveness. I mean, it's my hope that all of our panelists and everybody actually who's logged in is a volume responsive right now. If you're not, I hope that's not the case, right? So to your point that, we have to take the clinical context and really apply when someone is good insights to be able to know whether they're tolerant. But again, knowing it for the right clinical scenario is really where you take this entirety of cardiac, lung, and VEXUS. So let's kind of continue on to going now, shifting back, it is Kidney Month. Want to go back into the idea of looking at renal pathologies. And Megan, you gave us a great intro about your experience over a decade ago with starting on the value of evaluating point of care ultrasound for renal assessment and is particularly for hydronephrosis detected. Could you give us a little more insights and talk a little bit about the results you found in this paper here?
Yeah, sure. So I think, there was a lot of energy around trying to figure out how to incorporate point of care ultrasound into the initial assessment of patients with suspected renal colic, and whether there's added value to getting a CT scan, or can we make some of these decisions with just point of care ultrasound. And this study that we did at Boston Medical Center and a lot of similar studies that were kind of done all around the same time, we're trying to figure out, number one, can point of care ultrasound compare to CT in regards to identifying hydronephrosis. Now, the shortcoming of ultrasound in assessing for renal colic is that you're much less likely to actually visualize the stone unless it's very proximal, like near the kidney, or very distal, like near the UVJ. And really assessing the size is not as accurate as the CAT scan. So, those are all like expected management data points. If the stone is large and very proximal in the ureteral tract, it's going to be much less likely to spontaneously pass versus a smaller stone closer to the UVJ. Probably you're going to be able to tell that patient that they're going to have some pain for a few days, but they'll likely pass it without any sort of surgery or intervention. So the other things in this study, and there's some other studies that kind of looked similarly, was is the degree of hydronephrosis. In this particular study, we just looked at no hydro, mild, moderate, severe. There's also like a four graded system where there's sort of like a mild, moderate, severe. So whichever score you use there. But there has been some data to suggest that if you have moderate hydro, your chance of having one of those larger stones that might be a little bit more clinically significant is higher. So that's useful clinically. So if you have a patient who comes in with flank pain, again, lower probability of an alternative diagnosis. So ideally a young patient who has hematuria and who has the symptoms that seem most likely renal colic, and you do see hydro, that really makes you feel more reassured that that's probably the diagnosis. This may be a larger stone. So you may want to, actually go ahead and preemptively get them an appointment with urology in 1 to 2 weeks, give them return precautions for infection or pain that's not controlled at home. And you could, potentially with shared decision-making, send the patient home with those instructions and not get a CAT scan at that time. So that was sort of kind of the overall goal. There's been some decision tools that have been published that have been validated and very useful, especially in the training setting when we're trying to teach residents how to make these decisions. There's the Stone score, and then the Stone Plus that study done by some colleagues down at Yale, and so they looked at certain characteristics that could help you to find lower risk patients for complications. So looked at stone size, the timing, so more acute presentation. I'm sorry, not stone size, the symptoms, so nausea, whether there was hematuria or not, and there's some race, and there's the grading scale. And then incorporating in point of care ultrasound sort of helps with some of those mild, the in-between scores where it actually bumps you up a level to be more certain that you're dealing with an uncomplicated kidney stone where you can defer a CAT scan. So those are kind of helpful ways to think through this as well. In general, also just my last point would be the biggest thing about whether to decide whether to get a CAT scan versus just doing your point of care ultrasound is also how concerned are you about an alternate diagnosis, because that's what none of us want to miss, a AAA or some sort of infectious process or benzoteric ischemia or something like that. So in those high stone score patients, which are those like most likely uncomplicated renal colic patients, the incidence of a significant misdiagnosis is very low. It's less than 1%, whereas in the more like kind of moderate to lower probability uncomplicated stones. So those more like ambiguous cases, there's as much as like 3 to 4% of patients you might miss something if you don't get a CAT scan. So it's sort of, you know, weighing your risk tolerance as far as whether to get a CAT scan or not in those particular patients. So that's sort of the algorithm I sort of think through when I'm trying to decide whether to go ahead and get a CAT scan when we're seeing patients with flank pain.
I was one of the nice things about some of the renal protocols where you have a patient, for instance, over 65 and a smoker, and they get plugged into the renal protocol, you know, to slide over and look at the aorta with the ultrasound as well as the tool right in the hand to offload that one risk. That was a strategy that some of the sites have started doing.
Yeah, for sure. And, you know, you may end up diagnosing something like polycystic kidney disease to explain your pain and hematuria, or might find like an obstructing bladder mass. I had one case where there was unilateral hydro, and then also imaging the bladder, there was a bladder tumor that was sitting right at the like left UVJ that was causing unilateral hydro. So, I mean, these are all things that could have easily been missed if you didn't do a complete bedside ultrasound.
Thanks, Megan. Some great insights. So we're getting close to the top of the hour. I do want to let's dive into a few cases, but we'll keep a close look at the Q&A. So if anybody, feel free to ask any questions as we pull these up. But you know, just to the panelists, let's just pull up some images, and these are images on some of the patients that you've scanned. You know, doing point of care ultrasound here, and if the panelists could just talk a little bit about what we're seeing here about, you know, cardiac function and lung function. And then we'll go into a VEXUS diagram here. Yeah. So, Ramesh, do you want to?
Sure. You can see the first video, if you can see it played there. You can see that you can get an idea of the left ventricular function there simply by, this is the parasternal long axis view. I think it's from my butterfly, if I'm not mistaken. And it shows that the mitral valve is not touching the anterior valve of the ventricle, and also you can see the aortic valve on the other side. So that gives me a feeling that there's at least a moderate reduction in ejection fraction, maybe around 30% or so. But this is approximate. There's a lot of other reasons, but at least gives you a clue. The next one was a pleural effusion. I think, again, there's one of my pictures. I think it showed a pleural effusion there. We could see the diaphragm. I think the original pictures were way better. This is a picture of a picture of a picture. That's probably why, but it was helping. And then you can see some B lines of the lung there, if you can see that there. And this again is a diaphragm. And the third picture, I think you can, if you can play that one, it shows you can count the B lines in one of the.
Yeah, this is a still of that capture of.
Oh, that's a still. Okay,
it's a still of quantifying those B lines, but you know, multiple looking at heart and lung to see that congestion status.
Yeah.
Let's dive in now to looking at, assuming that was the same patient, to the panelists evaluating here. This is a view of the IVC. What's the takeaway here for that IVC?
Yeah, well, you can see the IVC is dilated. I don't think I put the measurement on this one, but it looks pretty plethoric there. And you can see the hepatic vein. The key with the IVC is make sure you can see it emptying into the right atrium. Otherwise, you don't call it an IVC because you could easily mistake an aorta for the right IVC. That's a novice mistake, which I teach my residents all the time. Unless you can see it emptying into the right atrium, don't call it an IVC. I usually go with a cross-section view like Abhilash had mentioned to make sure you're not getting the edge of the IVC there. It could be looking smaller than it really is.
And then here's a hepatic vein
VEXUS,
scan.
yeah.
VEXUS, yeah. Who would like to take away and try to describe, assuming that we can make some interpretations of having an EKG and seeing, well, we see one thing here, a singular downsloping waveform, right? So does that give insights? Again, we don't have the overlay of the EKG here, but.
I'll tell Abhilash to take this.
Yeah, no, I mean, like, I think when you have only, when you know the duration of cardiac cycle and you're seeing only one wave below the baseline, then it's easy, right? You don't have to most of the time identify S and D waves because you don't have like two waves side by side. if there is only one wave remaining below the baseline, most likely it's diastolic wave. The way you think about it is like when the tricuspid valve is open, the blood has to flow from right atrium to right ventricle. Therefore, the blood must go from hepatic vein to IVC to the right atrium. So that must be D wave. Rare exception can exist. For example, in tamponade, you have right-sided collapse, right? Then the D wave can disappear or reverse. So, and here, like you're seeing one below the baseline wave, and there is a huge gap between the next wave, and there you can see like two tiny waves. So most likely this represents diastolic only pattern or severe congestion, and above the baseline you have a tiny A wave followed by a systolic reversal wave. So it's severe congestion basically. Yeah, whether it's because of fluid overload or because of pre-existing structural tricuspid regurgitation because of a pacemaker lead, it's all up to you to evaluate in the clinical context.
Well, yeah, and so let's dive into another example here of this image here. So here we have a similar Vexus waveform here on the right, but now looking at this cardiac viewpoint, insights here in terms of now, what do you think from this PLAX view and potentially how it could be a different representation?
This is a patient of mine who actually had a diagnosis, a proven amyloidosis. I mean, you can see that left ventricular hypertrophy. If I remember the numbers right, if you have a 1.4 centimeter or greater thickness of the left ventricular wall, the risk of the possibility of amyloid is significantly. And nowadays we're seeing a lot of diastolic heart failure, and that is why I sent you this picture. This was a very classic case of amyloidosis with diastolic heart failure on that one. And the other one on the right side is another hepatic vein. You can see the hepatic vein beautifully emptying into the IVC. This was a right upper quadrant picture. And you can again see both a singular wave down here. Again, without the ECG, as Abhilash points out all the time, you gotta be taken with the pinch of salt. But you see a lot of positive wave. I don't have the color Doppler on this one. Otherwise, this probably was both a red and a blue on the hepatic vein.
Yeah, so interesting insights, right? Two completely different cardiac pathologies and pictures, right, with showing that same sort of finding on the Vexus. And, again, to our earlier discussion, really trying to understand how you have to take the two together to really adjust your management. All right, I know we're coming to time. Let's go into the idea of looking for hydronephrosis. Peter, if maybe we can just quickly talk about this scan here and just say some quick tidbits about hydronephrosis.
Well, hydronephrosis is the grading systems are really designed to assess whether there's obstruction at all, and then with the level of obstruction. So a grade 0, when you look at a normal kidney, the center looks white. That's renal fat, and it's white because all the drainage systems are potential spaces. There's nothing blocking up any fluid. And then as the obstruction becomes higher grade, there's more and more dilatation coming from renal. And on this image, it's down towards the bottom, where the ureter is draining from the kidney, and then it slowly expands up towards the calyces. So this is a very high grade obstruction because all the architecture of the kidney already is going all the way up towards the renal cortex. So the more the obstruction, the more damage to initially just the more space that gets occupied by fluid, and then ultimately the more damage to the kidney itself. So the grading system is a way to communicate really amongst different providers evaluating kidney structure, what level of fluid is backing up out of the ureter.
Great, and such great discussion. We're at the hour. I would maybe just for another 30 seconds, just ask the panelists if they could give one last takeaway about, the value of POCUS in your practice and to our audience, how you feel they should take on, learning POCUS and what steps they can take. Maybe Abhilash, could you start?
POCUS, you have to I think the key is to know your skill set and the limitations of the equipment that you are using. And ultrasound is not new. So radiologists know ultrasound, cardiologists know ultrasound of the heart. So you can always find resources at your institution to learn ultrasound. So maximize utilizing your institutional resources. That's what I would say.
Great. Megan?
I think depending on what your specialty is, figuring out how best you think point-of-care ultrasound can help you answer your clinical questions and take better care of patients, whether it's like using it in clinic so you don't have to send your patient for an additional study, using it for procedural guidance, and not getting caught in the weeds of all the other things if that's not something that's going to be helpful for you. And certainly I would emphasize just making sure that you get the right training and rather thinking of it as an extension of the stethoscope, it's really its own skill set that requires training and really respect for the pitfalls and false positive, false negative diagnoses.
Thanks. Ramesh?
Yeah, absolutely. But remember, the eye only sees what the brain knows. So remember to know what you're looking for. Otherwise, you won't know. You should at least have a diagnosis in your mind, then look for the options and make sure you don't make any mistakes. The problem with misinterpreting and then getting a bad rap is the key. So training and continuously monitoring. It's easier to interpret the image, but it's actually harder in ultrasound to acquire the image. And that is the key. You need a lot of practice.
Thank you. One more thank you to the panelists. I think it's been an excellent discussion. Just want to emphasize that to that point, Ramesh, so many different societies are now endorsing POCUS workshops, certifications, curriculums. This is just a sampling of what's out there. So encourage our audience to be able to go and evaluate, avenues for them to learn more about POCUS and how they can approach it into their practice. And it's expanding by the year. Peter, any last words? And then we'll sign off.
If you want to flip up to the nephrolithiasis slide. Yeah, no, thank you all. This has been a great discussion. And to the point, early on, the concept of whole body scanning is you have to be humble in what we're doing and learn the skill set, but always remember to take that next look. And this is an example of looking at the bladder to identify that someone has nephrolithiasis by looking at the bladder versus looking at the kidney. And so just remember, as much as you have to be humble about what we're doing and to get the training, is that if you don't look, you don't see. And so remember to take that. If there's a clinical question that needs answering, try and take that next step to get that next look to try and get that whole picture for the patient that we're taking care of. And great discussion. Thank you all.
One more time. Thanks to the panelists. Thanks for all our attendees, and look forward to next month.
Thank you for the opportunity. It was actually a
Thank you.
good discussion.
Thank you.
Thank you all.